There we go. Hello, everyone. Welcome to the 2021 updates in NHLBI and GINA Guidelines. I'm Antonia Sawyer, and I am going to be your moderator for this session. I have made sure that the recording is happening, so we are good on my first call of duties. And without further ado, I would like to please introduce our speaker, Dr. Kirsten M. Kloepfer. She specializes in allergy and asthma for Riley Allergy and Asthma. Dr. Kloepfer earned her medical degree at St. George University School of Medicine. She then completed an internship and residency at the University of Arkansas College of Medicine and a fellowship at the University of Wisconsin School of Medicine. So without further ado, Dr. Kloepfer, please take it away.
Thank you. And I'd like to thank everyone, or thank the organizers for inviting me today to talk about updates in the guidelines. So I don't have any disclosures for today's talk. So we'll talk about the new guidelines, some of the rationale behind the changes and the major updates that we're seeing, and implications for clinical practice, both utilizing this new SMART therapy and using intermittent inhaled corticosteroids. So there are two sets of guidelines that we follow when we practice. We follow the GINA guidelines and the NHLBI EPR4 guidelines. The GINA guidelines are updated every year, and the 2020 guidelines have come out. And then the EPR4, the EPR3 was published in 2007, and just in 2020 came out with the EPR4 guidelines. So those are not published quite as frequently. The biggest new recommendation of both of these sets of guidelines is to use inhaled corticosteroids and formoterol as a reliever in the treatment of mild asthma and in moderate to severe asthma, and we will discuss that today. And then also using inhaled steroids for even mild asthmatics. And that is a little bit of a change from current practice. So to start with an overview of asthma, we know that asthma symptoms are caused by two interrelated processes. Here in the picture, you can see what a normal airway looks like, and toward the right, what an asthmatic airway looks like. We see a lot of inflammation of the airway here. And then we see bronchoconstriction going on here with smooth muscle constriction. So there are therapies that have been developed to treat these things. Inhaled corticosteroids help with the inflammation, and then a bronchodilator helps with the bronchoconstriction. However, when it comes to inflammation, we don't see immediate relief when we use inhaled corticosteroids, and sometimes that can be difficult with patients. To get patients to understand why they need to take this medication every day because they don't feel immediate relief when they take it. In addition, the bronchodilators often provide immediate relief. And so there is a tendency for patients to become heavily reliant on these medications because they get that immediate relief. So they start to use their bronchodilator frequently. Did my screen just change for everyone?
It says asthma overview.
Okay, it just changed on my computer.
Okay.
Okay, thank you. So some of the treatment challenges we see when we prescribe medications to both children and adults with asthma are adherence to a daily regimen. So trying to remember to take a medication every single day and actually usually taking it twice daily can be quite difficult. And this is really difficult with patients who have mild disease because they feel okay most of the time. So then it becomes difficult to convince them to use a medication every day to prevent symptoms they may only have a couple times a year. We often see that people become reliant on albuterol for symptom relief. Again, because they get that immediate relief when they use albuterol, they then grab their albuterol whenever they have symptoms. And they don't understand that if they use their daily inhaled corticosteroid, that will prevent them from having those symptoms. Some ongoing talk about, especially in pediatrics, are side effects from using corticosteroids on a daily basis. Parents are often concerned about this and bring this up in clinic visits. The effects are significant or small, but they are significant. And it has been shown that growth velocity is affected when children use a daily inhaled corticosteroid for a long term. In addition, there are cost considerations when it comes to asthma. Inhalers are not cheap. So if patients are having to pay for a controller and a bronchodilator every month, that can be a significant amount of money that comes out of their pocket. And finally, there is potential for severe exacerbations, even in those with a history of mild asthma. There are reports of near fatal asthma or even fatal asthma in patients who previously were only using albuterol and have been diagnosed with mild asthma. About 16% with near fatal asthma had symptoms less than once per week in the preceding 3 months prior to their exacerbation. And there are case reports of fatal asthma in those who had been diagnosed with fatal disease previously. So there are two types of bronchodilators. There are short-acting beta agonist and long-acting beta agonist. The short-acting beta agonists are the albuterol and levoalbuterol, also known as Xopenex. This is frequently the first medication that's prescribed to an asthmatic. And then there are long-acting beta agonists, such as salmeterol, which is one of the combination medications we see in Advair, Wixela, Air Duo. There's vilanterol, which is in the Brio, Ellipta, and formoterol, which is found in Symbicort and Dulera. Again, the short-acting beta agonist, the onset of action is within 10 to 15 minutes, which is why adults and children with asthma experience that immediate relief when they use them. And then it lasts for a few hours after they take it. So it keeps their airways open for a short period of time. And then the one thing I want to point out is formoterol. What's interesting about this medication is even though it has a long duration of action about 12 hours, the onset of action of formoterol is similar to albuterol. So you do experience quick relief when you use formoterol. And that is the reason, and you'll see this in the upcoming slides, why the treatment recommendations are changing because of this quick onset of action. So this ICS formoterol combination contains this anti-inflammatory. So you are getting the steroid when you take it. And then you're also getting the bronchodilator that helps with bronchoconstriction. So this is why this medication is advantageous, because you can get relief from both symptoms by using one inhaler. And as I said, this combination comes, there's actually 3 inhalers now. There's the Symbicort here on the right, the red inhaler. And then there's generic budesonide formoterol, which is essentially generic Symbicort, and then Dulera, the blue inhaler here. The FDA has not technically updated their guidelines yet to use this as an on-demand therapy. So if we do start to use it for on-demand treatment, it will be considered to be off-label. And then just to note, this does not apply to any other combination inhaler. So you cannot use Advair, the Brio, Ellipta, or the Air Duo to as an immediate rescue inhaler, like you can with the Symbicort and the Dulera, which is, we'll talk about again in the guidelines. So some of the new strategies using this ICS formoterol combination is to use it at an as-needed basis. In the guidelines, we'll see that this is typically anybody who is 12 years of age and up to use this combination rather than albuterol. And they use it in the same fashion they would use their albuterol. So if they're having symptoms, instead of grabbing their albuterol inhaler, they're going to grab this Dulera or Symbicort. And then when they do this, they're not on daily medication. So this is for somebody that has more of a mild asthma phenotype, and they can just use the combination as needed. And that would be their one and only inhaler. It's also being used now for both daily use and as needed. This is used in children down to the age of 4. It's a single inhaler therapy. So it's also called SMART therapy, which stands for single maintenance and reliever therapy. So again, they have one inhaler that they use. And so they use their inhaler on a daily basis to prevent the inflammation that we see. And then they also use it on demand. So then when they start to have symptoms, they still are going to grab that same inhaler and use it for their immediate symptoms, because then the formoterol is going to kick in and help with those immediate symptoms that they have, as well as having that extra dose of corticosteroid to help with the inflammation that they're experiencing. And so current dosing is using it 1 to 2 puffs every 4 to 6 hours. And the amount of dosing is age dependent. And we'll talk about that in a future slide. So first we'll talk about mild asthma. And I'll start out with a case of a 25-year-old who has well-controlled asthma and is on low-dose ICS-formoterol. So is on Advair. Last round of oral steroids was over a year ago, has been to the ER previously, but it was several years ago, denies nighttime symptoms, is having very few daytime symptoms and is using albuterol maybe twice per month, is active and tolerates activity well and denies any symptoms with activity, and really wants to stop using medication every day because he feels like he doesn't need it. So talking about the ICS-formoterol as a reliever only, there have now been multiple studies that have looked at using this combination, and that's looked at over 10,000 patients so far. When we look at moderate to severe exacerbations, we see that when we use the combination as a reliever only, so they're not on a daily controller, we see a 50 to 60% reduction compared to placebo. So it works for these patients. And this can be seen in the graphs here at the right, both looking at severe exacerbations and moderate to severe exacerbations. When we looked at the probability of having an exacerbation here on the y-axis versus the number of weeks out from study start, we see this blue line up at the top. So that was our control group. And then there's both a red line and a black line down here. The red line are the subjects who used on-demand therapy. And so they used the budesonide-formoterol only when they had symptoms, versus the black line who used budesonide every single day, regardless of their symptoms. And you can see that the outcomes are similar. So these studies show within severe asthma and in moderate or severe asthma, very similar findings that using on-demand therapy is equally as effective as using a daily inhaled corticosteroid. And then also there's, when not pictured here, is that they had very similar number of asthma control days between those using on-demand therapy and those using daily treatment for their mild asthma. And then when they looked at the dosing of this, and so how much corticosteroid did the patient receive every day, the on-demand treatment group only took in about 57 micrograms of steroid per day versus 340 per day in those who use budesonide every single day. So you're getting a lot less steroid and potentially would have a lot less side effects from this daily use of a steroid. So when we look at the guidelines, the GINA guidelines, and actually these are also in the 2021 guidelines, anybody that is 12 years of age and up who are on step 1 or step 2 therapy, the recommendation, the preferred controller now is to use low dose inhaled corticosteroid with formoterol. And that is their the medication that they would take. So for step 1, it would be as needed. So that would be like using it as almost like as a reliever. So they would just take it as needed. Step 2, they could take a low dose inhaled corticosteroid alone or use this as needed ICS-formoterol. And after seeing some patients and changing them to this treatment, they actually prefer this method, this as needed low dose ICS-formoterol, and often come back and report to me that they feel like it works better. And dosing for this is using low dose ICS, so Symbicort 80 or Dulera 50. and having them use 1 to 2 puffs every time they need it. And then they can use it every 4 to 6 hours. There are some guidelines for maximum dosing. So anyone ages 4 to 11 that use this dosing could use up to 8 puffs per day. And those who are 12 and up would use up to 12 puffs a day. And if they're needing more than that, then they need to contact us for further guidance. This also can be used prior to activity. So they could use 1 to 2 puffs of this combination inhaler before they exercise. And it's thought that this might actually be a more effective way to pre-treat for exercise, especially in older children or adults who are going to exercise for long periods of time and frequently need albuterol more than once when they're exercising. And that's because the formoterol lasts for a longer period of time. So one of the key points to using this medication is that it is as needed and it's going to replace albuterol. So you don't give them the combination inhaler to use on demand and then also give them albuterol. You would not prescribe albuterol at all. You would only prescribe the combination inhaler. So going back to our case, if we look at the guidelines and are treating a 25-year-old who's been well controlled on a combination therapy and is taking it every day and would like to stop because they're not having any symptoms, you could consider the GINA guidelines, which use both low dose ICS-formoterol, and you could use it as needed, or you could replace both inhalers and put them on a low dose inhaled corticosteroid and then have them use a short-acting beta agonist as needed. But this is the preferred method now, this low dose ICS-formoterol. If you follow NHLBI guidelines, the newest guidelines say that they should continue their inhaled corticosteroid daily and then use a short-acting beta agonist as needed, or use their inhaled corticosteroid and short-acting beta agonist as needed. So the NHLBI guidelines have them using a two inhaler method where they would use inhaled corticosteroids in addition to their albuterol. But again, that's 2 inhalers. So honestly, in our practice, we really are starting to shift to the GINA guidelines and giving them 1 inhaler just because it's so much more practical. So switching gears a bit and going to moderate to severe asthma and talking about the SMART therapy. So we'll start out with a case. We have a 10-year-old female who wheezes with viruses and high pollen counts. She has daytime symptoms and is using albuterol at least once per week. She's been on systemic steroids 3 times in the last year. She's been to the ER twice in the last year, but has not been hospitalized. She's currently taking a Flovent 110 micrograms, 2 puffs twice a day, and has good adherence. So this patient could potentially be a candidate for what we call SMART therapy, the single maintenance and reliever therapy. The concept for this treatment is that daily inhaled corticosteroids and formoterol provide the day-to-day control of their symptoms. And then during exacerbations, they still take this medication because they're going to get the bronchodilator effect from the formoterol, and they're going to get additional steroid to help with the acute inflammation they're experiencing. It will provide relief of their bronchospasm symptoms, and you're increasing that anti-inflammatory. And the aim of this treatment is to avoid oral steroids, ER visits, and hospitalizations. When we look at the studies that were performed looking at this type of treatment, where they had patients take their inhaled corticosteroid and formoterol daily. So these are patients that are more step 3, step 4, and then using it as needed. They found both here in one study, you can see that the solid line here are the patients who were taking it as prescribed and then as needed, versus the groups who are taking just the combination and then using short-acting beta agonist. They did much better when it came to exacerbations. And then similar down here, exacerbations here on the y-axis versus time in days over the course of the study. Those who were on using it daily and then on demand did better than those who were just using short-acting beta agonist reliever with their daily medication. And And so we do see that this does reduce severe exacerbation in patients that are in step 3 and step 4 therapy. Now when we look at the NHLBI guidelines, they are actually recommending the same type of treatment. So using the daily and as needed combination of low dose inhaled corticosteroid and formoterol for step 3 treatment. And then with step 4 treatment, they use medium dose ICS-formoterol. And so they're increasing the dose of inhaled corticosteroid they take on a daily basis. And just to note, that was for the NHLBI guidelines in 5 to 11-year-olds, and that the max dose of formoterol should be 36 micrograms per day. So you have to be careful about how many puffs per day they take. And then those who are 12 and up, similar recommendations, again, using the combination low dose ICS-formoterol and using the low dose in step 3 and the medium dose in step 4. And so getting back to our case, this again was a 10-year-old female who wheezes when she gets sick and also clearly has some allergic asthma component and is having more frequent symptoms, has needed steroids several times and has been in the ER. We would recommend putting her on either on the step 3 of GINA, the GINA guidelines, which show that she should be on a low dose inhaled corticosteroid with a LABA, the medium dose ICS plus a short acting beta agonist, which is albuterol, which is what we have been doing prior to these newest updated guidelines, or low dose inhaled corticosteroids with formoterol, both daily and as needed. And then the NHLBI guidelines agree with this recommendation in this age group to use this low dose inhaled corticosteroid formoterol combination and using it daily and as needed, a maximum of 8 puffs a day since she's 10 years of age. And so even though GINA still gives us options, we now are kind of following the same ones that the NHLBI recommended. Again, because one inhaler is so much easier than having multiple inhalers and getting them confused. So what about intermittent ICS for mild asthma? We are seeing that using intermittent inhaled corticosteroid use is now included at even the lowest steps of therapy. There's also an option to be for those with mild to moderate exacerbations. So the patients that just seem to have 2 exacerbations per year whenever they get sick, but are asymptomatic between illnesses that tend to seem to be virally induced, we would recommend inhaled corticosteroids now for these patients. And then there is evidence for this of using this intermittent inhaled corticosteroids with short-acting beta agonists. There are variable results from different studies, and there's not the strongest level of recommendation in the guidelines. So this really pertains to anyone under the age of 12. So the guidelines have not yet recommended using this combination of ICS-formoterol for those in step 1 and step 2 levels of asthma control for treatment of children under the age of 12. And so they're still recommending using, or instead they're recommended using inhaled corticosteroids with their albuterol. And so this is where the guidelines get a bit confusing because we are seeing 2 different recommendations coming out of the NHLBI and out of GINA. The NHLBI guidelines are not always, they don't always review all of the literature every single time. They're making bigger changes. And so GINA guidelines come out every year. So we tend to follow GINA guidelines whenever possible. But the age ranges are varying for the 2 guidelines. And when they start talking about step 1 treatment, and again, this is the people with infrequent exacerbations and not getting hospitalized for their exacerbations. For the children who are less than 4 years, NHLBI guidelines point to the studies that show that high dose inhaled corticosteroids twice daily for 7 days at the onset of respiratory symptoms is the way to treat these patients. and is the recommended way to treat these patients. So we often call this putting them in the yellow zone treatment. So when they're in the green zone on their asthma action plan, they are not on a daily inhaler, but as soon as they get sick, we put them on high dose inhaled corticosteroids. The GINA guidelines don't really address this other than to say that if somebody fits this phenotype where they have viral induced wheeze but no other symptoms, that you really should watch them closely and be concerned that they are at risk for having an asthma exacerbation and may develop asthma at school age. When we look at the NHLBI guidelines in those who are 12 years and up, at step 2, there is a recommendation to use low-dose inhaled corticosteroid, which would be Flovent 44 2 puffs. And you can give that after they take their short-acting beta agonist. So after they use their albuterol or Xopenex, they could take a low dose of inhaled corticosteroid if they're not wanting to use the combination of ICS-formoterol. GINA guidelines also has this as a possible option as well for anyone who is 6 and up. So there are some other options out there if using Symbicort or Dulera isn't possible. And so what about some of these existing guidelines that have been out? And what do you do when you see a patient who has been being treated on the previous guidelines and you're questioning whether they should be changed? So if they're well controlled on their current controller therapy, they don't necessarily need to be converted at this time. If they are good at following the current asthma action plan, we do not always change them. We do consider changing it around if we are needing to increase or decrease their therapy based off of their symptom control. If they are not well controlled on their current therapy, we often try to find out why they are not controlled. Is there an adherence issue? Are they getting inhalers confused? Is it a technique issue? Or is this just an inadequate regimen and they're having trouble following it? And sometimes switching to the SMART therapy or just using if there's step 1 or step 2, just using the ICS-formoterol combination works better for them because you're giving them one inhaler. So we then consider changing strategies in these patients. So some practical points to think about when you're implementing these plans. We really look to see what are the goals of the care. Are we really trying to minimize their exacerbations, their daily symptoms, or their medication use? And sometimes putting them on one inhaler will help with these, address these issues. How controlled are they? Is their lung function controlled? Are they having exacerbations? Can they tolerate activity? Are they ready to try something new? Sometimes they're ready to try a better way to treat their asthma. And then obviously health literacy always comes into play. And will the family be able to understand this shift in how they treat their asthma?
Dr. Kloepfer?
Yes, I'm out of time.
A reminder that you have about 2 minutes till question and answer time.
Okay. And then we do a lot of education telling them that this now is that this is their new reliever, or it is now both their controller and the reliever. And in fact, we're trying to get away from those words sometimes and just tell them that this is just their one medication, especially if they've never been on one before. That's all they know. And we try to get them to understand that they will not get albuterol anymore. So we're not giving them refills. They shouldn't get it refilled at the pharmacy. And they should not be grabbing their albuterol if we're putting them on this combination therapy. And we really try to counsel, don't double up, don't use your ICS-formoterol when you're in trouble and then turn around and take your albuterol again. We recognize that guidelines are not universally known because these are new changes that we're seeing. So we try to counsel our patients to be careful if they go to the ER or to see another physician and they're telling somebody they've been using their Symbicort every 4 hours, that physician may not be aware of this new recommendation. And so for that reason, we really try to educate our patients. We have them teach back what we tell them, and we give them a copy of an asthma action plan so they can take it with them to an urgent care visit or an ER visit or any other healthcare interaction, so they can show them that we have told them to take their Symbicort or Dulera as a reliever. And then asthma action plans. We always fill out an asthma action plan when we see patients. An example of what one would look like for somebody that we're putting on Symbicort or Dulera as needed. In their green zone, they would not be on a daily controller. They might be pre-treating and using 1 to 2 puffs prior to exercise. In their yellow zone, we then tell them to take 1 to 2 puffs as needed up to every 6 hours. And then in their red zone, they could take 2 puffs every 4 to 6, and then tell them not to exceed their maximum amount of doses and to contact us if they're needing it more frequently. So things to think of when you're prescribing this are that school nurses and personnel at school may not know about this new technique, and so it might need to be explained why they're needing just the 1 inhaler and why they don't have albuterol. And then again, as I said, EDs and urgent care sometimes don't know about these new shifts and guidelines. And then insurance, we are working with insurance companies currently trying to get them to adopt these newest guidelines because some patients may be running out of this medication before the month is up if they're using it, especially if they're using smart therapy and they're using it twice a day and then on demand, or pre-treating with exercise before exercise with this medication. And so Dr. Krupp has been working tirelessly with these insurance companies, especially Medicaid, to get this covered. And so big take-home points today. There's early introduction of inhaled steroids now. It is being recommended to use them as soon as the diagnosis is made and using it in conjunction with a bronchodilator. Intermittent inhaled corticosteroids is sometimes appropriate for those with infrequent mild to moderate exacerbations that are typically virally induced and they are symptom-free between illnesses. ICS-formoterol is the preferred reliever. In the GINA guidelines, it's the reliever only in the 12 and up group with infrequent exacerbations. And then in both guidelines now, the SMART strategy as young as 4 years of age, using it as a controller and a reliever, and just being mindful of maximal dosage and mindful of logistics and insurance challenges. And then with that, I will close. And if anybody has any questions, please feel free to email me at the below email address or reach out to Dr. Krupp.
Thank you, Dr. Kloepfer. I am impressed with you getting that amount of information as time allowed. That was quite impressive. So yes, to echo what Dr. Kloepfer said, we open it up for questions from anyone who is participating in this session this morning. If there are no questions, I have placed in the chat the next set of links. We do have a short 10-minute break for you to be able to grab your lunch, stretch your legs, go walk outside before the rain gets you, and we'll be all set for our next set of sessions. So applause to you, Dr. Kloepfer. Thank you again so much. I learned a lot.